I would start by making one comment regarding the fact that these studies on natural evolution suggest that the impact of treatment seems to be minimal, or perhaps there is a laid-back approach to control of disease. I've always thought that there's an observer effect, so that when we treat our patients nowadays, earlier, more intensely, we are not able to see the natural evolution of the disease. But on the other hand, I can see recent studies, mostly from Scandinavian countries, where the evolution seems not to be affected by treatment. Is that because we are not treating our patients, let's say, proactively enough? Is that perhaps because treatment does not impact evolution? What's your take on that? Yeah.
I can start. It's still to be determined, of course, but I think we have to note a couple of things. Firstly, that it's probably beneficial to intervene early in the disease course, and we have some data on that from the Stockholm psoriasis cohort, that the patients who was treated early in the disease course actually had a lower risk of having severe psoriasis 10 years later than patients who were treated with systemics later in the disease course. So, early intervention may be an important factor. And then, of course, it's difficult to know, right? Because also you need to follow patients for a long time and also account for treatment. And you also need to account for the fact that, treatment affects disease severity. So it's very difficult to disentangle the relationship between disease severity and treatment over time.
According to your data, it seems that severity at onset is more important than duration of disease since diagnosis.
Yes, most likely. But then again, of course, another factor that I think one needs to take into consideration is that patients age. And, aging itself, which is, of course, correlated with the disease severity, that affects, your immune system in the body, right? So, for example, if you look at that graph with average PASI score over time, you actually see a decrease with age.
Mm-hmm.
So that's also a factor to account. So it's a complex matter to disentangle.
Thank you.
Yeah, I'll just add, I totally agree with you, Axel. And it's a good question, because the trend now is more to treat early and hard and so on. But maybe, and that kind of makes sense somehow because of other diseases and to limit the long-term effect, maybe. But what I was aiming to say is that maybe we can still treat early, but then have a much more active or proactive way to suspend treatments and then see what happens. Because I have many patients on biologics, I have no idea. Maybe I could stop tomorrow and nothing happens. So, yeah.
Treat early when deserved. Questions from the floor?
Great talks, thanks to both of you. One question for you, Irène, and one question for you. For you, Irène, you mentioned you were cautious. You wouldn't comment on the epidermal compartment too much in their interaction with the resident memory T cells. You alluded to that. Can you elaborate a bit about do you believe that there is a compartment of inflammatory resident memory T cells which is independent of the trained memory epidermal stem cell compartments that Schutinek and Eileen Fuchs unraveled? So that's the...
Yeah, okay. Yeah, thank you. That's a good question. I've been mainly working on epidermis, so I've been a big advocate for these cells. But it's true that many things happen in the dermis as well. I think we've been more limited by when we work with human tissue as the epidermis we know are kind of secluded from the blood, so we kind of can conclude that what we see in the epidermis is something that stays in the epidermis. While the dermis, when you take the biopsies, you take samples, and then it's much more difficult. Now with the new techniques and the spatial transcriptomic, maybe we can have some answers. But before that, it was very difficult to make sure 100% sure that what you're looking at is not blood cells and really, really resident cells. So I think that's why, that's what I was trying to say, that it's maybe more technical thing that made us focus more on the epidermis, but I'm still a very big advocate for epidermis. Yeah. I'm not, did I answer your question? Or?
Absolutely,
okay.
Absolutely. Now the question regarding the epidemiology, I will be very quick, but do you have any proxy that would integrate chronicity of the very early onset flare would that kind of profile be enriched for the very early onset during childhood, for instance, psoriasis versus in adulthood?
Yeah, that's something that we're currently studying. So there is, the patients in this particular cohort was 15 years or older. And I think that is an important factor because probably this very young patient population probably have a distinct disease course, and that might be driven by different genetic mechanisms even. And that's, we have a cohort that we follow, but there are no results so far. We're currently following up those patients.
Thank you.
Wayne?
Wayne Gulliver from Canada. It's a comment maybe all three could discuss. That's the natural history of psoriasis in pregnant women because it's linked to HLA-CW6. We see about a third of the patients improve or even resolve. And we also know that the natural history is that many of them will recur after. And so have any of you studied that group of patients? Because it embraces all aspects of what we discussed this morning.
It's a very good question. I haven't worked on pregnant women. Of course, the immune system will change during pregnancy, but I don't have any good patient sampling or no. I'm not sure. Johann, you have something? Or?
We haven't done it yet, but I agree. It's a fascinating thing that is going on. Pregnancy is such a complex immunological state, and we always kind of avoid doing stuff with pregnant women. So I think that's the main threshold. But I agree, there's something really interesting. Not everybody gets better during pregnancy, but
about a third, yeah. And I actually do. It costs like $25 to do an HLA-CW6. So I actually test them and say, yes, you have the gene, and there's a good chance that you'll get better during your pregnancy. So it has a clinical utility as well.
Yeah, no, I agree with you. We should look.
We should.
Thank you. Yeah, please.
Thank you for the excellent lectures. So, which signals increase the survival of resident T cells in the skin? So we know something about the Langerhans cells in that process in the survival of resident T cells.
So if I got it right, your question is about Langerhans cells interactions with TRM cells in the epidermis? Yeah, yes. So yeah, of course, there are interactions. I showed a little bit that in the resolved psoriasis, the Langerhans cells still have an upregulation of IL-23, and it's been also recently published that the IL-23 is very important for the TRM cells, for the sustainment of the population. So that could be one of the factors that makes them stay there, yeah.
Which other factors increase the survival of resident T cells?
Yeah, I mean, it's not, I mean, there are more and more knowledge about that, but we know that, for instance, the antigen, because some cells, some T cells will need to encounter the antigen regularly in order not to die, and they are not doing that. They don't need that, the resident T cells. What we know is that they need, to intake the fatty acids, and there are some factors. I mean, IL-23 would be one. Yeah.
So we know something about the melanocytes in that process, and ADAM-TCL5 antigen in the survival of resident T cells, or not at present?
You mean if the melanocytes are important for the survival? I don't know anything about that, but that's a good question.
Because ADAM-TCL5 antigen is related to the disease. Okay.
No, that's a
Thank
very
you
good
so
question.
much.
Is anyone has a comment on that? No? Okay, thank you.
Thank you. Irene, most studies on relapse are focused on, let's so-called spontaneous relapse. And on the other hand, is there any role of studies regarding Koepner-induced appearance of lesions? Is there any role for this myeloid-derived interleukin-23 in induction of lesions by Koebner, or is, what is the link between mechanical stress and inflammation in psoriasis? Any?
I mean, for me, don't pretend that I'm right on that, but for me, Koebner is really, since it's really linked to the severity of the disease and the systemic side of the disease, to me it's more like a breach in the circulation that will actually allow the skin and the circulation to communicate much more than before.
You mean regulating circulating regulatory cells or tissue-resident memory cells?
No, I mean circulating, because during severe disease you have an increase of circulating cytokines. It's not major, but an increase of circulating immune cells that are more active. So I think that's this communication that when you have a breach, you have a scar or something, then they will come back. I mean, they will come inside the skin, while in a normal situation they would not.
I find some, in my opinion, there are missing studies on hot spots in plaques induced by, for instance, withdrawal of occlusive clobetasol. Or any evidence on what drives this relapse in hotspots?
That's a very good question as well. I cannot recall anything on that actually, but that's very interesting, of course.
Sometimes you see lesions relapse on the periphery or as hotspots, and really sometimes the sampling is very important.
No, I agree. We should look at that. Yeah.
Thank you.
Thank you.